Mycetoma, a long-neglected tropical disease. Mycetoma is a chronic inflammatory disease due to a bacterial or fungal infection of an open wound. Whether it is bacterial or fungal, the clinical presentation remains the same. There is subcutaneous tumefication, sinuses that drain pus and blood, and granules with the causative agent. If left untreated, the infection can spread to deeper tissues, such as the muscle and bone, and destroy them. If allowed to continue without treatment, amputation of the affected limb may have to be performed. So we can see that left neglected, this disease has extremely negative consequences that affect all aspects of health, as well as productivity of individuals and communities. What is worse is that it makes it very hard for these communities, which are already impoverished, to better themselves economically. Mycetoma was first described in Western literature in 1694. In the mid-19th century, the fungal etiology of the disease was established, and it was called mycetoma for the first time, which literally means fungal tumor. The first hospital dedicated to mycetoma was opened in the 1950s by Dr. Julian Taylor, and in 1990 the antifungal itraconazole was released and is still widely used today. A year later, the Mycetoma Research Center was opened in Sudan. Although this disease has been documented since the 1600s, it wasn't until May 28, 2016 that mycetoma was listed as a neglected tropical disease. Mycetoma is endemic in what has been termed the Mycetoma Belt, and the affected countries are highlighted in this map. This map was created by totaling published reported cases since the 1960s for each country, and dividing it by the country's current population as of 2013. Mauritania had the highest prevalence with 3.49 per 100,000, and Sudan had the second highest prevalence with 1.81 per 100,000. It was also reported that the highest number of cases were observed in 21 to 30-year-olds. This gives us some indication of which countries and age groups were most affected, but an obvious shortfall is that not all reported cases would have been published in the literature, and this only provides a rough estimation of the global burden of disease. Mycetoma caused by bacteria is called actinomycetoma, and is most often found in Central and South America. There are various antibiotics that can be used for treatment, and patients are usually treated in two phases. There's an initial intensive phase where a combination of 2 antibiotics is given every day for 5 weeks. After this phase, the patients are then released and required to continue taking antibiotics long term. When a fungus is the causative agent, it's called Eumycetoma, and is more commonly seen in Africa. Eumycetoma progresses more slowly than actinomycetoma, and is often more debilitating. The standard treatment is expensive and inadequate, and involves surgical removal or reduction of the lesions, and then long-term use of antifungals. These medications can become toxic after being used for an extended period of time, and even with long-term treatment and surgery, there's still a high chance of reoccurrence. Now this table gives an overview of the range of techniques that are used to differentiate mycetoma from other similar diseases, as well as differentiate actinomycetoma from eumycetoma. It is often necessary to perform at least one of each type of test to obtain a definitive diagnosis. And I won't go through the results of each. This is really just to highlight that the process is quite tedious and hinders rapid case identification and collection of accurate epidemiological data, and there is a dire need for more rapid and accurate diagnostic tools. Molecular techniques such as PCR are currently showing the most promise for achieving this goal. Pricks from thorns contaminated with causative agents as a mode of transmission has been most favored throughout history. Whether there are any intermediate infectors involved is still being investigated, and there are still some questions regarding the natural habitat of organisms involved because they are found in both soil and dung. It is also unclear whether transmission will always cause mycetoma, or if there are factors that predispose the host to development. What is certain is that there has to be injury, and the causative agent has to reach the subcutaneous tissue. There also hasn't been any documented human-to-human transmission. The foot is affected about 70% of the time, but anywhere on the body can be affected. Now, as you may have come to realize, this is a disease that affects the poor. It particularly affects those that walk or work with no shoes. Shepherds and farmers are at even higher risk because they work barefoot with animals whose dung may harbor the causative agents. And these are often roles for men, which may be why the male-to-female ratio for mycetoma is about 5 to 1. Inadequate housing and living close to livestock also increases vulnerability. And exacerbating this is poor hygienic practices, inadequate nutrition, and individuals that may be immunocompromised due to co-infections such as HIV. Now, though mycetoma is hard to treat in some cases, primary prevention is achievable. At this level, there should be community-based education, provision of shoes for these communities, and improvement of community infrastructure to decrease exposure to potential agents. There's also a need to identify primary reservoirs of infection to better prevent transmission. The secondary level will require developing fast and cheap diagnostic tools for early case detection. Finally, at the tertiary level, there is a need for establishing more healthcare facilities in endemic areas and the development of safer and more effective drugs. At all of these levels, there is a need to provide incentives for research. And these are the references if you want to read more about it. And thank you for listening to my presentation.